Our mission is to eliminate addiction through prevention, advocacy, and recovery support. Tonight, we will be covering the topic of substance use disorder and its intersection with the criminal justice system. I am so excited just to welcome our two guests and to also remind you that this week, as well as next week, will be offered virtually only. As you can see, we are not at the hub. We are here at the Hanley Foundation headquarters in West Palm Beach, Florida. Before we jump into our series, I also like to remind everyone who registered for last week's session with Joe Considine that we will be moving it to August 25th, and that session will be virtual as well. You can register online at hanleyfoundation.org, and if you've registered previously, you will not be impacted. Tonight, I would like to introduce you to our speakers from the University of South Florida. Faculty members Abigail Shockley and Caitlin Haldorson Melendez. Abigail Shockley is the director of the Criminal Justice, Mental Health, and Substance Abuse Technical Assistance Center at USF, where she oversees the center's activities, contract compliance, and coordinates and provides training and technical assistance related to implementation of reinvestment programs throughout the state of Florida. Prior to joining the center, Abby served as consultant for behavioral health programs, assisting with strategic planning, grant writing, development of compliance and business plans, and assessing programs for implementation of best practices for individuals with substance use disorder and mental illness. She previously served as a senior policy analyst with the New Hampshire Department of Health and Human Services, where her work focused on several substance use disorder policy analysis and development, along with expansion and oversight of Medicaid coverage for those with SUD. During her time with New Hampshire's Department of Health and Human Services, she also served as the project director for implementation of the State Opioid Response Grant, including oversight of program development for delivering behavioral health services and expanding the use of medication-assisted treatment for individuals involved in New Hampshire's criminal justice system. Next, Caitlin Haldorson Melendez, who is the Assistant Program Director at the Criminal Justice, Mental Health, and Substance Abuse Technical Assistance Center at USF. At the center, she is responsible for facilitation of training and technical assistance, website management, and maintaining regular communication with grantees and consultants for the DCF Criminal Justice Reinvestment Grant Program. She's also the technical report writer for grant program reports written to inform the Florida Department of Children and Families and the Florida Legislature. She earned a Master's of Arts in Criminology at USF in 2016 and a Master's of Science in Child and Adolescent Behavioral Health in 2021. Since starting at the center 5 years ago, Caitlin has assisted in facilitation of over 17 sequential Intercept mappings across the state, which help to promote system-wide changes in behavioral health and criminal and juvenile justice systems. Her research interests lie in the criminal justice and juvenile justice system, crossover population of youth involved in both the behavioral health and statewide justice systems. Please welcome Abigail Shockley and Caitlin Haldorson Melendez.
Hi, everybody. Thank you so much for joining us this evening. Thank you to the Hanley Foundation for inviting us to speak. We're very excited about tonight's session. And I'm going to go ahead and get started. Okay, so you know who we are. Again, this is Abby Shockley, joined here by Caitlin Melendez, and we're going to talk to you tonight about substance use disorder and the intersection with the criminal justice system. Just so I set the stage for kind of what we're going to do tonight, I'm going to introduce the center that Clarice referenced and what we do for the state of Florida. We'll level set you with some terminology because we love to use acronyms in this field. Talk a little bit about some background and data so we're all working from the same information, and then offer some solutions to challenges that are faced in this field, and talk about the role that community members and advocates can play. So our center is funded by the Florida Department of Children and Families, and we really serve a subset of organizations and counties that receive a state grant that's called the Criminal Justice, Mental Health, and Substance Abuse Reinvestment Grant. By serving them, I mean, we provide training and technical assistance to grantees across the state. We travel across the state virtually now, but in person prior to COVID. And we provide folks to access to kind of statewide and national subject matter experts. And the grantees that we serve are really looking to transform their systems that work with juvenile and adult populations that have substance use, mental illness, and are involved or at risk of involvement with the criminal justice system. And just as a point of reference, this is just a visual representation of some of the travel we've done across the state. I know in Clarice's introduction, she referenced sequential intercept mapping, which we'll talk about in the solutions section. But this just shows some of the activities we've conducted through those mappings as I referenced our state travel. So to level set us all around the acronyms that we're going to use, I just want to kind of highlight some of the bigger ones. So when we talk about SUD, we'll be thinking about substance use disorder. When I reference behavioral health, that's really a catch-all for both substance use and mental health combined. Sometimes in the systems we work in, behavioral health is seen as, mental health, services only, but in the context of this presentation, it will be referencing both of those. MI is shorthand for mental illness, and again, SIM is acronym for sequential intercept mapping. So before Kate gets into some more of the data, I do want to just talk a little bit about the prevalence of substance use disorders in the United States generally. 19.7 million adults have a substance use disorder. Of those, it's about split, 74% have alcohol and 78 have illicit drug use disorder. And then 1 out of 8 of that population experience both alcohol and illicit substance use disorder, which is commonly referred to in the field as polysubstance use. And this equates to about a 6.5% lifetime substance rate for adults in the United States, and almost 9% of lifetime substance use of illicit drugs for the adult population. So we do know that we have a problem with both alcohol and illicit drugs in our country. And of that population, 10.2 million adults have a co-occurring mental health and substance use disorder. And co-occurring disorders, as I just referenced, are really those that are both substance use and mental health and sometimes feed one another. And that's because they're related and they contribute to one another. There's kind of 3, common factors associated with co-occurring disorders. 1 in 4 individuals with serious mental illness also have a substance use disorder. And again, these are common risk factors, genetics and stress, and they affect the same regions of the brain, trauma and ACEs, which we'll talk more about in a little bit. These are all kind of shared risk factors for folks who have a mental illness and also those who are more likely to have challenges with addiction. The other second kind of common thread here is that they kind of help to feed one another because mental illness may contribute to substance use. And then also folks may self-medicate with substances to address underlying mental health problems that have been untreated. And then substance use and addiction, because of how it interacts with the certain regions of the brain, can contribute to the development of mental illness and other mood disorders. And so it's important to understand kind of the basic biology and the relationship between these 2 very, very common disorders, because oftentimes systems are designed to treat them in a bubble in individual silos, and that perpetuates challenges with kind of continued involvement in systems. I do want to take a moment to talk a little bit more about kind of the first bullet here and the impact of the acronym ACEs on these risk factors. This is a common acronym in the field, and it refers to adverse childhood experiences, which really kind of includes a catch-all of kind of household dysfunction and various form of abuse and neglects that occur for folks before the age of 18. And the ACE framework has been studied for quite some time, and it's really used to assist medical and mental health professionals to better understand the impact that negative childhood experience have on an individual's health. Primarily when it comes to involvement with the criminal justice system, a study in 2017 showed that individuals that have experienced 4 or more categories of adverse childhood experiences had significant increases in risks to health related to substance use, depression, and suicide risk. And there's also a link between increased numbers of adverse childhood experiences and other chronic conditions, and early contact with the criminal justice system being one of those adverse childhood experiences that can negatively impact development and decision making. And so understanding ACEs really helps to explain kind of the generational cycle of criminal justice involvement, which we'll talk a little bit more about when we talk about trauma later on. So this slide I really like because it helps to set the precedent for why we talk about co-occurring disorders in the context of substance use disorder generally. As we mentioned, individuals with substance use disorder often have a underlying co-occurring mental health issue and vice versa. And individuals with substance use disorder are also more likely than those who do not have substance use disorder to have a co-occurring disorder. And oftentimes, this kind of just visual representation of how systems treat these conditions can explain why people cycle in and out of the same systems, because systems often, especially prior to the last, 5 to 8-ish years when funding and policies were created to kind of drive integration of care. Addiction treatment was kind of in one bubble, mental health treatment was in another, and you kind of had to go get treated somewhere first for your addiction or your mental health issue before you could get treated kind of for those issues collectively. And you really can't treat one without treating the other. So without adequate attention to both, as soon as one is treating, the other pops up and leads to risk behaviors that just kind of feed that cycle that I referenced. So again, this is kind of sets the stage for some of the underlying challenges that folks who are involved in our criminal justice system who have these behavioral health conditions are faced with. And I'm going to pass it on to Kate now to do a bit of a more history around the data around the intersection, specifically with the criminal justice system and some of those statistics.
Thanks, Abby. So as Abby mentioned, now we're going to shift the conversation a bit and talk about why the intersection of criminal justice is important, especially in the context of substance use disorders. So as you all may see from these slides or these statistics here, treatment needs among justice-involved populations are greater than among the general population. So according to the Center on Addiction, an estimated 65% of the US prison population has an active substance use disorder. And another 20% doesn't meet the criteria for substance use disorder, but we're still under the influence of drugs or alcohol when they committed their crime. So just to continue this a little further, in regards to co-occurring disorders, mental illness is 4 to 6 times higher in jails and 3 to 4 times higher in prisons compared to the general population. And more than 2/3 of jail detainees and half of prison inmates have a substance use disorder compared to 9% in the general population. And lastly, only 5% of those with opioid use disorders in jails and prisons receive medication-assisted treatment. And this is an evidence-based approach to treating opioid use disorders nationally. And we'll get into that later on in the presentation as well. So we're just going to continue on here. So these ROI, these return on investment estimates are from a study conducted in 2007 by the National Drug Intelligence Center. And it's estimated that criminal justice costs to society since 2007 have gone up greatly as due to the increase in associated with prescription drug misuse. And so it's important here to emphasize that we could shift these costs for punitive, incarceration and treatment to treating substance use disorders and have a really great, approach to spending as opposed to shift those spending in the justice system. Next slide, please. So research has also provided evidence that racial disparities in the treatment of adults has existed for decades. It's important to recognize because justice system involvement, as Abby mentioned, perpetuates the cycle of disadvantage and trauma already experienced by minority populations, including poverty, unemployment, and low educational attainment. And so when we're looking at the justice system and these disparities, nearly 80% of individuals in federal prison and almost 60% of individuals in state prison for drug offenses are Black or Latino. And so this is significant because in strategic planning efforts, we have to address these underlying social factors that aggregate disproportionalities of individuals who come in contact with both the behavioral health and justice systems. And the largest percentage increase in drug overdose deaths in recent years among African Americans has been due to barriers in treatment, such as stigma, bias, socioeconomic status, and reentry planning, and then their treatment interruption during arrest. So this is why the strategic planning, which we'll get into in a few slides, is going to be really important. Next slide, please. So the next two slides just kind of depict visually how important it is to talk about racial disparities in justice and in substance use. So, for instance, 17 million whites reported having used an illicit drug within the last month, and 4 million Blacks reported having used an illicit drug within the last month. However, drug incarceration is more prevalent among Black individuals, despite this disparity because of the stereotypes. And here's another visual depiction. So Black people are treated more harshly for drug possession, as I just mentioned. And so this is another reason why the disparities must be addressed. So herein lies the challenge. As you all may know from your experiences working in these systems or interacting with these systems, it's challenging to juggle numerous demands, and these services can become very costly, especially when individuals are involved in multiple systems simultaneously. For instance, the mental health, the substance use system, the criminal justice system. These services are costly, and these individuals are often the same individual cycling through these systems. And so the solution to this challenge is cross-systems collaboration or sequential intercept mapping. So sequential intercept mapping, as Abby mentioned earlier, is a strategic planning process that assesses community assets and gaps for individuals with substance use disorders and mental health problems involved in the criminal justice system. And from this process, we know that individuals flow through the justice system in a predictable way. And so these intercepts present key points of interception for individuals in order to, ensure prompt access to treatment, opportunities to diversion, and linkages to community services. And through SIM, we work to transform fragmented systems. So this is the sequential intercept model. And when we're working with communities, we literally go through each of these intercepts and map the system. So starting with community services at intercept 0 and going all the way to community corrections at intercept 5. And we identify where to begin and target interventions for individuals through this process. As we know, recovery is nonlinear, but this is a linear model for us to target these interventions, which we'll get into a little bit later. So why? So for instance, individuals with substance use disorders in the justice system, we hope to promote and support recovery-oriented services and access to services among reentry specifically. And that's why it's so important to get stakeholders together in a collaborative strategic planning effort such as the SIM. So through doing this, we identify priorities and gaps, develop an action plan, assist leadership in following up on these priorities, and hopefully address those silos that Abby talked about in the beginning. These silos in the different systems in behavioral health and criminal justice really come to light in these mapping exercises, and through getting all these stakeholders in the same room together is really helpful, because oftentimes we don't know what happens in one intercept as opposed to another intercept. So this is the solution, the SIM. If you remember the map that we pulled up just a few slides ago, it allows us to identify best practices in working with this population. And through conducting these mappings across the state, we have, figured out what the best practices here are in Florida. And we are going to share some of those with you through the next slides. And Abby's going to have the opportunity to do so. So I'm going to turn it over to you, Abby.
Thank you, Kate. So again, Kate talked about kind of how we've used the SIM to promote some of the best practices that exist. And so what I'm going to do next is really kind of talk about some of the best practices and approaches to substance use and co-occurring disorders in the justice system, kind of across that kind of mapping visual that Kate presented a few minutes ago. So when we talk about those early intercepts, those intercepts 0 and 1, really those kind of alert to kind of early intervention and screening services. And I like to think of screening as kind of the physical of your emotional health. The same way you get a physical at your primary care doctor, kind of screening helps to assess kind of risk factors, identify early signs and symptoms, and identify kind of potential substance use disorder or risk behaviors that can then trigger a referral to a clinician, much like your kind of physical screening triggers referrals to specialists if there's medical conditions that are found. And so in those early intercepts, we really promote kind of in-jail screening or assessment, or screening or assessment, at arrest. And one of the challenges we see across the state and, nationally even, is that there's just not a consistency in practices, but there are evidence-based tools to use. And so it's really important to promote kind of consistent use and promotion of policies that require consistent use of these evidence-based tools to make sure that we're kind of understanding who's coming into our criminal justice system and the prevalence of those that may be coming in that have a substance use disorder or co-occurring. One of the other challenges we see with screening is that because this population has so many risk factors associated with them, this may be the first time someone's ever screened for a substance use disorder. And so they may have cycled in and out of the justice system so many times before and never been screened. And a lot of the challenges that brought them to the justice system in the first place may have been able to be addressed had kind of adequate screening been in place. And then the other challenge we hear often is that there's not a lot of resources to provide treatment. Unfortunately, jails are kind of the default treatment center for a lot of folks with substance use disorder, and really treatment should be provided in the community. And it's really challenging when you do find, you do embed kind of consistent screening practices into a process. And then the question then becomes, okay, well, we have folks who, have screened positive for substance use disorder or indicate a need for intervention, but where do we send them next? So we'll talk about that a little bit in the next slide, but it's really important to kind of understand that that's why we kind of apply a systemic approach to these conversations, because you can't just address kind of one issue without thinking about kind of supporting the back end of the supports that are necessary to be successful with this. So then those kind of middle intercepts that Caitlin, if you think of that visual, so we have the early intervention in 0 and 1, and then kind of 2 and 3 are looking at how we can treat substance use disorder that's identified for those who are in the justice system. And again, the great thing here is that there's a lot of best practices out there. There's a lot of really solid programs through drug treatment court, medication assisted treatment, again, which is that evidence-based practice for opioid use disorder, in jail treatment that's coordinated with community providers so that folks transition from in jail services immediately upon release to a community provider. Distribution of naloxone, or more commonly known as Narcan, to address high rates of overdose fatalities, and then the increasing use of peer support services and recovery support services. these are kind of just some of the high level examples of some of the services that exist, not only nationwide, but here locally in the state. And there's different communities have kind of different programs at different stages of maturity, but there's a lot of really good resources available to treat substance use disorders in the justice system. And one of the benefits to doing that is that for better or worse, you have a captive audience of folks who are incarcerated. And so why not provide them with resources that can help get them on a better path for when they reenter the community? And I do want to just take a quick moment here to emphasize that across the system, there's been kind of a really big push for kind of what's called trauma-informed care. And this goes back to those adverse childhood experiences I referenced earlier, because we have to assume with this population in particular, trauma-informed care really just kind of assumes that an individual is more likely than not to have some type of history of trauma. And you have to acknowledge that throughout an entire system to understand why people might be resistant to change or resistant to help. Understanding the role that trauma may play in somebody's life, and recognizing when something may be a sign of a reaction to a traumatic experience instead of a resistance to treatment. One kind of very common diagnosis for folks with substance use disorder who are using substances to kind of self-medicate underlying mental health issues is post-traumatic stress disorder, which can be developed as a response to trauma. Here we have examples of an accident, war, violent personal assault, and PTSD is correlated with kind of increased risk of arrest, and recidivism, which is kind of returning, following release. And so this graphic just kind of explains that in a more visual detail. It kind of is important that our systems are not re-traumatizing individuals who are already traumatized. Again, thinking about how policies and things that are in place just from a logistics standpoint can be traumatic unintentionally. And so this is a really great graphic to help people understand how you may be able to modify, these processes to be more empowering and understanding of the impact that trauma has on individuals. So on the kind of back end of the SIM model is that reentry and community transition in 4 and 5. And it's really, really important that folks have some type of coordinated reentry because oftentimes people are kind of sent to kind of off with their own, to deal with things on their own and given limited supports, and there's not really kind of continuity of care. And so the model that we promote across the state is this, what's called the APIC model. And it really just is kind of a best practices framework for developing a team-based approach to reentry planning. That includes the individual, that includes community services that are out in the community and, works with them ahead of time before it's kind of their discharge date to move into the community with the supports that they need. Again, this is just, a visual representation of that model. And the reason this is important is because, particularly with the opioid epidemic that we have now, is that people who are reentering the community from incarceration are over 40 times more likely to die from an opioid overdose. And this is a really critical window from, between up to 2 weeks after they're released. And this is because typically what happens is folks go back to using the same amount of opioids that they were using prior to arrest, and their body has reduced a tolerance over that time frame, and that leads to a fatal overdose. And so it is so critical that people are not just kind of left to fend for themselves. And I'm looking at time, and I wasn't sure if I'd have time to do this, but I do want to kind of drive a point home about this with just a kind of quick mental activity here. So, because reentry planning is so, so critical. I just think about some things you plan to do on the next day or so, your kind of mental to-do list that you run through before you go to bed. You got to place a grocery order, going to dinner with friends, whatever it is. And just take a second to think of a few of those things. And then I want you to kind of take everything on off the list that requires money, transportation, or a phone. I'll assume that there's kind of not much left after that. And so when people are entering the community, they're really given a bunch of to-do lists like that. And most often, none of them say the same thing, and none of the providers who give people that list are talking to each other. So there's all these expectations that people have for somebody. So their parole officer may want to see them at 3, but a treatment provider is doing an intake for them at 1, and they need to go to that treatment provider intake in order to start treatment, or they risk relapse. And then they hear, that same day that Child and Family Services can only give them a noon to 1 window to visit with their child because that's the only time they could find somebody to provide supervision. So in order to do those things, they have to take the bus, and there's no way they can be all 3 places at once. This is kind of what happens every day when people reenter the community, and then, we're surprised when they end up back in the system. And this is really why kind of coordinating care and expectations among providers is really critical. There's been a lot of progress on this, but things do fall short for people. And it's one of the reasons that we see people cycling in and out of treatment in criminal justice settings. As Caitlin alluded to, the good thing through the sequential intercept mapping process is that we can strengthen those relationships and provide opportunities for more cross collaboration. And there are lots of evidence-based practices like that APIC model that can be used to kind of create a reentry team or a coordinated team to help people plan for reentry, to mitigate some of those issues about multiple schedules and multiple demands. So there is hope, but it's really just important to understand why it's not kind of so easy for people to stay in recovery or keep them out of jail when those are the demands that are placed upon them. So as we wrap up, I love this slide because I think it does a good job of explaining the importance of how we talk about this population and how we address these issues. This slide is just kind of visual representation of a study that was done really about language. So a study presented to participants 2 stories. The stories were exactly the same, except the person in the story in one instance was referred to as a substance abuser. And in the second instance, the person in the story was referred to as having a substance use disorder. For the study, the participants who read the story about the substance abuser, they believed that that person was less likely to benefit from treatment, more likely to benefit from punishment, more likely to be threatening, more likely to be blamed for their problems, and more able to control their substance use without help. And so we all have a role in promoting language that empowers people to seek help and not to perpetuate bias. And so as we shift our language in society around this issue, I'm hopeful that we'll be able to see changes at the systemic level that really kind of help systems to see substance use disorder for the medical condition that it is and treat it as such. And I just think that this is such a powerful example of how language can kind of define someone's trajectory or how people see them. And so I think it's important to keep that in mind. So I know this is all kind of heavy information. We threw some data at you. We talked about some really kind of complex social issues that sometimes kind of seem impossible to change. And we also know that so many families and communities are touched by addiction and the risk of criminal justice involvement that brings. So I did want to kind of close out our presentation with some ways that you can make a difference locally to help us turn the tide here in Florida. Much like the slide I just reviewed, I love the idea of kind of promoting recovery-oriented language in your own circles. Share with people what you learned about that language study. And, when you talk about, substance use, maybe, think about other language that you can use to describe people that is more kind of person-centered. Speak to elected officials about this. We have our website and countless others. I'm sure Hanley has plenty of resources, about kind of best practices and resources that could kind of divert some funds to kind of the criminal justice kind of punitive side to kind of treating these issues. Calling out stigma when you see it, when you see statements in the media, or when you see statements in a meeting, or at presented somewhere, to just point out where things seem more judgmental and more kind of value judgments instead of addressing substance use disorder as a medical condition. And volunteer and get involved. If this is something that speaks to you, if anything we've said, I'm sure Hanley is a great resource for kind of where you can go next to make sure that your voice is heard, and that you can kind of help to be the ripple effect of change. So I hope this leaves you feeling empowered and hopeful for change. And I think we do have kind of time here for Q&A now.
All right. Thank you so much, Caitlin and Abigail, for your expertise in this subject matter. We do have a few questions from our audience in the chat. I'm going to go ahead and just go through those quickly. The first question, you mentioned in your presentation trauma-informed care and just how allies and professionals should really make it an effort to be trauma-informed. Does USF offer a trauma-informed care training?
That's really interesting. I don't know. I don't want to speak out of turn. I'm sure there's some faculty member who has done some type of training on this. I don't know that we have any that's kind of widely disseminated. The Technical Assistance Center, we do training like that for grantees and grantee communities. So yes, and maybe, I guess is my answer. Yeah.
Thank you for that. So our next question, is naloxone required in all prisons or jails in case of an accidental overdose?
So my understanding, and again, I am not recent on having just transitioned from New England to Florida, now it's almost 2 years, so I don't have much of an excuse. But there's no kind of blanket requirement for naloxone. It is kind of a jail to jail or county by county decision. I would say, though, at this point, given how prevalent opioid overdose is, I would be surprised if there are any jails that don't have naloxone on site. However, there is no requirement for kind of widespread use or dissemination of it within jail or prison systems. And so that is a lot of times programs will use grant funds or use kind of new funds to create initiatives like that.
Wow, that's really interesting. It's good to know. Sort of a follow-up to that question is, do all Florida prisons have a psychiatrist or psychiatric resources on hand for inmates?
No. So that's another good question. I'm asking Kate if she knows of any that have been part of our SIMs that don't have some type of mental health services. I don't. Many jails and prisons contract out with a healthcare provider to provide those services. And generally, I would, again, especially just given how widespread these challenges are, generally they have some type of mental health professional as part of that medical team. I don't know to what extent there's any consistency in how often they are staffed with a psychiatrist. Oftentimes they may have a contract with a psychiatrist to prescribe medications as necessary, but there's not any type of, consistent treatment other than maybe med continuance or medication initiation. Kate, do we have any grantees that don't have some type of?
We actually have encountered that in a few communities, and through the SIM process, it has been addressed as a priority area to, initiate mental health treatment in the jails in those communities. There's often times where the sheriff's office may be in charge instead of a contracted provider. Unfortunately, we can't speak to prisons so much as jails, as we do focus on the jails rather than the state prison system.
Interesting. Okay, thank you for that. Our next question: what is the biggest problem you are facing now in the substance use disorder and criminal justice system intersection?
Oh man. Okay. So the easy answer for that would probably be resources for the needed services, but I also feel like that's the answer for everything. So my soapbox answer would probably be stigma and bias, and similar to kind of that slide I talked about with language, is kind of really building up sensitivity in the criminal justice setting for individuals with substance use disorder who may cycle in and out of the system, multiple times because of behaviors associated with their substance use. And just making sure that the criminal justice system sees those people as in need of help, and providing the supports necessary to move them towards recovery.
Awesome. Thank you so much. So our next question: has SIM been used in other areas other than the criminal justice system?
So not SIM in particular. So the SIM model was developed by a Policy Research Associates, which is a national firm, and it was developed specifically to address kind of the criminal justice system intersect with behavioral health conditions. However, the SIM is really a strategic planning model. It's a way to kind of do a deep dive into systems. And so although kind of the SIM model hasn't been used outside of the criminal justice system, a lot of the framework and the approach to community planning and kind of asset and gap analysis that the SIM contains certainly has been used. And, I would highly suggest its use to kind of help communities understand kind of systems at a more granular level.
Thank you for that. And our last and final question: are there any current statistics on the success or one-term success of diversion programs?
Yes, there are. I don't have them off the top of my head, but we'd be happy to share those with you guys to disseminate to folks.
Thank you. I think we would love to have that resource available. Now, so were there any other questions in the chat? Last call for questions.
I see one question. It looks like someone asked how often and what kind of family involvement is there. I think that speaks a bit to that, depending on how coordinated somebody's reentry process is, or even how coordinated somebody's in-jail treatment is. In an ideal world, the family is involved, receiving education about, the impact of substance use disorder and how they can be supportive, but also kind of set boundaries, and how they can also kind of promote recovery in their own, family unit. And so we don't see that in any kind of cohesive way, across the board right now, but it is kind of picking up steam. Family peer supports, family kind of engagement and parent partners and things like that are becoming kind of more and more common in kind of best practices and programs across the state and nationwide right now. And they're so valuable. I mean, that would be wonderful if more family involvement occurred.
We'll just piggyback off that and say we do try to really encourage family involvement and consumer involvement and peer involvement in our mapping exercises too. So it is a really important piece.
Awesome. Well, thank you, ladies, so much for joining us tonight. And thank you to our audience for your participation in the third session of our 7-part Summer Recovery Leadership Series. We are thrilled to have you, and please remember to register for next week's session by clicking the link in the chat box or visiting hanleyfoundation.org. Next week, we will be discussing stigma reduction with Dr. John Dybin, Chief Clinical Officer at Origins Behavioral Healthcare. And also, we will be sending out a survey after tonight's presentation. Please be sure to complete that at your earliest convenience. And remember that you will be entered into a drawing for a $25 Amazon gift card for your participation. Thank you. Have a wonderful night, and we will see you next Wednesday.